Dr. Deepak Sudhakaran with us, who is a palliative physician. He did his MD community medicine, and also he did a certificate course in pain and palliative medicine from Manipal. Now he is a palliative physician in Pallium, India, and also he is involved in research activities. He has around 3 years of experience in palliative care. Happy to see you. Happy to hear Dr. Deepak. Welcome and over to you.
Thank you so much, Sister Ji, for that kind introduction. A very good afternoon to one and all. I hope I'm audible. Is it clear enough?
Yes, you are.
All right. So I'll just start sharing my screen. It would be nice if we can have as many people as possible on video so that I can have a look at you all as well. And please feel free to interact via the chat or raise your hand or unmute yourself. Interrupt me whenever you wish to do so. It's not a problem. Okay, I hope my slides are visible, Sister Ji.
Yes.
All right. So I want everyone to be as active as possible on the chat. I'll be keeping on looking at the chats in between. So please do use the chat box as frequently as you can. Shall we all start? You can answer with a yes or a no. You won't have an option of no, even if you say so. But then just to ensure that we all are on the same page. All right, that's great. The presenter is here. Okay, so have all of you heard of this term delirium? So whatever questions I ask for, please do keep answering on the chat box. I'll keep checking it. So have all of you heard the term delirium? I think it's about time you must have heard it because it's been there in our dictionary since the first time it was used was in the year 1563. So that was quite a long ago. It's about time that we and common symptom, which is often seen in
You are muted.
Yeah. All right. So let's move on with our presentation. So what does delirium mean? Okay, delirium comes from a Latin term called as delirare, which means that to go off track. Okay, that means suppose in normal terms, a person will keep going straight, okay, on a path. But whenever you go from the normal path to deviate it a bit towards some other direction, that means we say that a person is going off track, right? So when a person departs from his usual normal behavior and starts having some sort of an abnormal behavior, that means he's going off track. Okay, that is when we call this as delirium. Can you, am I audible? Are you able to follow? Just respond on the chat, please. Okay. So what is it? Like I said, it is a behavioral abnormality. What happens over there? There is an acute confusional state. What do you mean by acute? Sudden onset, right? Acute means sudden onset. Now, in terms of delirium, sudden onset does not mean that in 1 minute you are okay and the next minute you develop a problem. It can be a few hours, okay? Within a few hours you develop an abnormality, or it can even be a few days. In this setting, as far as delirium is concerned, we will term this as acute. So an acute confusional state. But many a times we also go into some sort of confusion, right? The moment we wake up from sleep, many a times we are in confusion. All right, if something, some abnormal situation happens, suppose there is a sudden loud sound or something like that happens, suddenly we may be confused for some time that, oh my God, what is happening right now? You're not sure. So does that mean that we are in delirium? I want you to keep answering in the chat box. So definitely no. So it is an acute confusional state which is associated with a medical condition or intoxication, or there was some sort of, the person was used to taking some substance, maybe tobacco, it may be some drugs, it may be alcohol. He stopped it and now he is withdrawing from it. So when such situations happen, there will be an acute confusional state, and we'll say that the person is in going in for delirium. So what is confusion? Basically, a confusion is a mental and behavioral state of reduced comprehension, coherence, and capacity to reason. Let me simplify it for you. Comprehension means understanding. Coherence means he's not able to relate to what is happening around him. It may be daytime, but he's thinking that it is nighttime, or it may be nighttime and he's thinking that it is daytime. So he's not in relation to outside world. He is in a different state of his own, and he's beyond a capacity to reason. Right? You may try to make him understand that no, this is daytime. What are you saying? You can see the sunlight. You can see this, but he will not understand it. He will say something which is beyond. You are not able to reason with it. So it is a mental and behavioral state of reduced understanding, okay, and any capacity to reason. So what are the features? Basically, there are 4 features, okay. We'll be looking into it in detail, but right now let's look at this. There will be some sort of prodromal symptoms. Do you know what prodrome means? For example, before you get any viral fever, you know that there will be some 2 days before that you will start feeling very tired. You'll start feeling maybe nauseous. There'll be some symptoms like that, which in general you start feeling, oh, I'm not feeling well, something is wrong, maybe I'm going to get a fever. Similarly, there is a prodrome which can happen for before a person develops this acute confusional state. What are those prodromes? Restless. He'll be very restless. He may be irritable. He may have sleep disturbances, unable to sleep during night time. He may show some sort of aggression or anger, etc. So some prodrome symptoms may be there. Next is it's a fluctuating course. That is, it's not necessary that he'll continuously be having abnormal behavior. There may be periods of time when he is having normal behavior. So you will think that, oh, this guy is okay. There is no problem with him. But after 2 hours, when you go and see, he'll be having some abnormal behavior. So it will keep on having that fluctuating course. So up and down, it's called as waxing and waning, right? Waxing means the symptoms increases, and waning means it decreases. So there will be a fluctuating course. The person will have disorganized thinking. He's not sure about, his thinking won't be in the right sense. We'll be looking into it detailed. Incoherent speech, we are not able to understand what he is saying. Irrelevant talk may be there. He will have a reduced attention span. One moment he'll say that he is feeling hungry. The next moment he will say that he's not feeling hungry. Third time he'll say something else. Like completely unrelated topics, he will keep talking. So there's basically a reduced attention span. Increased or decreased psychomotor activity. Psychomotor means one is too much mental activity or very less mental activity, and motor means physical, right? Motor abnormalities may be there. Maybe he'll just have some abnormal movements of his hands like this, or he may just do some picking behavior, like some picking things, he's picking from the air, or if he's wearing some clothes, he may just keep pinching on his clothes, something like that. Some abnormal motor behavior will be there. Then affective symptoms. Affect means it is emotional. So there is some feelings inside him. He may show anger, he may show fear, he may show some sadness, he may cry. So basically emotional instability. Apart from this, many a times you will see that the person is angry, very agitated. He may have some violent behavior. He may abuse you. All of you are nurses working somewhere or the other. Have you seen patients like this having abnormal, aggressive behavior? sometimes abusing you, because of which you will get angry on them and you end up tying their hands and legs, or you'll tell the doctor, please give something to this patient so that he's sleeping most of the time. Have you had such experiences? Aggressive, angry patients, which has developed over a period of few hours or a few days. I'm not seeing any responses. I hope all of you are online, those who are not having your videos on as well. So while we wait for others to respond, I hope you guys do. And apart from that, there will be altered perception. Perception basically means that what are you seeing or what are you hearing? Sometimes you may see or hear things which are not a reality, which is just an illusion. This is what we call as hallucinations. Now, out of all these features, there is one hallmark for delirium, that is attention deficit. You may have asked the patient one question. For example, who is the patient who is sitting with you, taking care of you in the hospital right now? And before he's able to answer that, he may just start talking some other random thing like, I need to go somewhere, or I'm feeling hungry. He doesn't stick to one line of thought or one line of conversation which we are trying to have with him. He tends to deviate from whatever is happening around him. Is everyone able to follow? Is the sound okay? Are you guys able to see the presentation, the PPT? Is something getting stuck? Please respond on the chat, following which we'll proceed. Only Kanchan and Oyo are responding. I hope to get some responses from others as well. Sharanya, Bindu, Tracy, Jagrup, Gurpreet, Shintu. Are all of you there? All right, that's better. So moving on. So what are the causes? Probably this may be important for you as well, for your evaluation as well. So there are certain causes. For sake of easy remembering, I have written it as delirium itself. So D for drugs, any person who is under the influence of some sort of drugs, and many a times because there is withdrawal from drugs as well, right? So the person has been a long-standing habituated to alcoholism or other forms of drugs, and now he's trying to stop it. So there will be withdrawal, like we have already mentioned. E for eyes and ears. Now, the only reason why we are able to be oriented is because of our eyes and ears, right? We are able to see what is happening around us, so we know our surroundings, and we are able to hear. That's why we are able to be oriented what is happening around in our immediate surroundings. Now, many times in elderly patients or in patients with other some kind of diseases, slowly due to some abnormalities of the ears or the eyes, what you can see is that there is no visual perception or auditory perception. So when this starts happening over a chronic period of time, the person starts getting disoriented. He's not sure about whether it is daytime or what time of the day it is. So when these sort of things start happening over a long period of time, the person starts becoming disoriented or disorganized in his thoughts. Simple things, solutions like getting a spectacle or a hearing aid may solve the problem. Low oxygen states, obviously we all know that we can't survive without oxygen. So whenever there is an oxygen deprivation or reduced oxygen due to whatever reason, it may be a heart attack where the heart is not pumping enough blood, or it may be a stroke within the brain, or it may be an embolus inside the lungs because of which oxygen exchange is not happening into the blood. So in such circumstances, this can happen. In case of infections, wherever there is a focus of infection, basically, So many a times we may have some, for example, diabetic patients, they may get some small injury. They will not be aware of it because their nerves are so much damaged that they can't feel any injury which may happen to them. So this injury gets infected and then it spreads through the blood to all parts of the body. This kind of infection, if it is there, it can cause a delirium. In simple terms, what do we call this as? Can you guys share on the chat box? An infection which was first localized, then goes into the bloodstream and spreads everywhere, and the general condition of the patient starts worsening. What is this called as? All right, few more people. So Evangeline, because Evangeline has to present a case, must be wide awake for sure. I'm not so sure about the others. All right. So, right, that is septicemia or sepsis. Very true. Very correct. Next is retention. Mind is, okay, in palliative care settings, one of the major questions which we always ask is, have you passed stools today? Have you passed urine today? Extremely important questions. Funny in some situations where when we ask, the first question which we ask many a times ends up being this. One of the reasons is that it has got a direct bearing over the functional status of a person. If there is retention of urine or stools, there is a high adrenergic hyperdrive within something called as an adrenergic hyperdrive within a person's system. So when this happens, what happens is the delirium can worsen. Okay, we'll look into it further. That whenever there is basically delirium happens because of some chemical imbalance which happens, and whenever there is an adrenergic drive, there is a excess of certain hormones which are released into the bloodstream, which leads to worsening of the delirium. So what we try doing, the treatment will be to ensure that the person passes bowel or passes urine, or you put that catheter if there is a urinary block, etc. Next is I. I is for ictal. Ictal means, what does ictal mean? Come back to chat. What does ictal mean? Sister G's and brothers, what does ictal mean? You need not take this much time to respond. I think all of you can chat in one word or one sentence, like in 2-3 words quickly. I think we should put up a rule that those who don't respond should not get attendance. What does ictal mean? Yeah, I think Evangeline is given. Evangeline, you need not respond anymore. It's understood that you're there. Right. So this is basically some seizure which is happening. Okay. Some seizure which is happening. So whenever immediately after a fits or a seizure happens, what happens is the person will be in sudden confusion. He doesn't know where he is, what is happening around him. He doesn't remember suddenly what was happening with him. Sometimes they pass stools and urine also on the spot. So this kind of a state. So ictal, basically post-ictal state, can also cause confusion. Again, you for uncontrolled pain, always remember it is not just palliative care. Many of the times it is pain and palliative care. Okay. So if the person is having uncontrolled pain due to whatever reason, it may be a cancer related illness or it may be a non-cancer illness. Any of the state, if there is uncontrolled pain, it can lead to delirium. Metabolic causes, if there is glucose, sodium, potassium, magnesium imbalances happening, either hypo or hyper, that is either less or more, it can lead to delirium. And finally, S. S is subdural hematomas. Right? So subdural hematoma means there is some collection of, due to whatever reason, either a fall or some trauma, there is some blood collection which is there inside the skull. So whenever that happens, it is called as a subdural hematoma. Right. Moving forward. So there it is. Yeah. Now also remember that So this is what I was telling. Basically, what is happening is there is some chemical imbalance happening within our brain. And when this chemical imbalance happens, that time the person starts having abnormal behavior. So you can see that there are certain neurotransmitters which is there on the left side: dopamine, acetylcholine, serotonin. These must be the common ones which you have heard. Apart from this, also there are certain neurotransmitters. And based on the kind of neurotransmitter which you suspect is the cause of the delirium, you may have to start on certain medications. And when you start on these medications, it may have some effect on the delirium. Right. So what is the burden of delirium? Remember that in about 30% of hospitalized patients, especially if the patient is in an ICU, okay, and towards end of life, when the last few days of their life, when they are passing from this life, 85% of such patients may have delirium. So in hospitalized settings, especially in ICU settings, you know that the patient is continuously inside the ICU. The lights are always on. The monitors are always beeping. So many sounds happening. People are always walking around. So in between all this, where do you expect the patient to be oriented, right? So always remember, very, very commonly seen in ICU. And other reason is in ICU, most of the patients are there because there are so many kinds of illnesses because of which they have ended up in an ICU. So as you saw the causes, delirium causes, they may have multiple causes because of which they are having delirium. Right. So what is the impact of delirium? One is there will be a functional decline. Okay. So whenever the person, suppose an elderly person, as he is growing old, his functional status decreases, right? He's not able to move around as much, not able to do as much activities of daily living, and not as much as balanced while walking as well. Now this person has a fall. After a fall, this person has a fracture. Just out of interest, can any of you tell me what is one of the most commonest fracture which an elderly person gets after a fall? Come on the chat. If somebody gives the right answer, I'll give you a virtual chocolate after the session is over. One of the most commonest. Yes, very correct, very correct. Sumit brother and sister Tracy, sister Kanchan, yes. So fracture neck of femur, basically a neck of femur or a hip fracture is something very commonly seen. So once this fracture develops, the person, many a times we won't go for any active procedure for this patient, like, because they're elderly, they may not be able to tolerate an extensive surgery. Even if they do the surgery, for whatever reason, they may not recover that soon from the surgery. So many a times these people end up being immobilized. And once they're immobilized, again, there is a functional decline. And then the vicious cycle continues. Many a times there will be incontinence, okay? Incontinence of urine or of feces due to different pathological conditions. Hydration and nutrition, if suppose the person is not well hydrated or his nutritional status is poor, in these statuses, again metabolic disturbances can happen. And in a person having delirium, sometimes you may want to feed the patient, okay, out of your concern for the patient, or the concern of a caregiver, they want to give food and water to the patient, but because of abnormal behavior, what do? They'll just hit the plate and throw the food away, or they may get the glass of water from you and put it on your face itself. These kind of behaviors may happen. So impact of delirium, again, their functional status will decline, nutrition will decline, right? And then they end up being an emotional burden. Emotional burden is usually what we think of is in terms of the caregiver. The caregiver has to see, just imagine somebody, your loved one who has been with you for many years, 30, 40 years. Somebody like that undergoing a disease and having abnormal behavior in such a way that many times they are not able to recognize you. Many times they may be aggressive towards their loved ones. They may even tend to be violent. So it ends up being a big emotional burden for the person who is seeing all this. And remember one thing, being in delirium also causes distress to the person themselves. Okay, keep that in mind as well. So why delirium? Why does this actually happen? Even if we told all the causes, but then why does this happen? To be frank, the mechanism is still under investigation. It is very poorly understood. One of the things which is hypothesized or is being thought of is that there is a system called as reticular activating system. We have got a brain stem. Inside the brain stem, there is a reticular activating system. So this activating system, like the name suggests, is it keeps you activated. And there are certain neurotransmitters present over here also. So what happens if this activating system gets dull, you also become dull, right? So whenever there is some issue in the reticular activating system or there is a chemical imbalance, majority of the times there are only two neurotransmitters which is implicated. One is acetylcholine and next is dopamine. Very commonly, all of us have heard. That is deficiency of acetylcholine or there is excess of dopamine. These are major neurotransmitters which if not given, if it's not functioning properly, can cause psychomotor abnormalities. Can all of you tell one disease? Come to the chat box and tell one disease in which there is a dopamine abnormality. That is, dopamine is abnormal in the brain. So dopamine is a major neurotransmitter and it causes, if there is less dopamine within the brain due to some changes which happen inside the brain, one major disease happens, which is a very common disease. If I tell it, all of you will know it. Very good, Evangeline, Sunita. Parkinson's, right? So look over here. In delirium, there is excess of dopamine, too much of dopamine inside the brain. Okay. Now, coming to the next point, remember one thing, despite of all these things, not all individuals exposed to the same insult will develop signs of delirium. For example, if I may come and pinch you, okay, if I come and pinch you, some people, if I just go and touch, they will shout. Some people I have to touch and press, then only they will shout. Some people I will pinch very hard and still they will not shout, right? So not all individuals exposed to the same insult will develop signs of delirium. Okay, let's understand this a little better. So here you can see, right? So there are certain individual risk factors and there are certain triggering factors. Okay. Now look at it. Suppose the individual risk factor, if it is low, what do you mean by individual risk factor? That means that something is wrong with myself right now. Now suppose issues with myself is low. For example, I am young age right now. Okay. So chances of me having some illness is less. I do not have any dementia-like illness, right? In elderly, because of brain becoming shrunken, they may start developing memory loss. That is called as dementia in simple terms. So there is no dementia and I don't have any chronic diseases like diabetes or hypertension. I don't have it yet. Okay, so all my individual risk factors are low, right? Are low. Now, if a person like me who is having low individual risk factors, if I have some very high, very severe, very serious triggering factor, only then there is chance of me going into delirium. Okay. For example, I go into sepsis, like you said, my blood is completely infected. Sepsis, it can be a life-threatening condition. I underwent a high-risk surgical procedure, right? That is, there is some issue in my brain and a neurosurgical procedure had to be done. So now high-risk surgical procedure or some sort of drug toxicity I got right now. Some drug I took excess in amount. Okay. Now I'm in toxicity. So for a young person or for a person with very less individual, very low risk factors, for such a person needs very high triggering factors. Okay. But let us look at the other side. Suppose it is an elderly person. It is an elderly person having some chronic illness, or they're having some memory loss, or they're having multiple diseases. For such a person, something as small as a loud sound or a bright light or a change in their environment. They started living in a new house. You wanted to do something for your elderly parent, and then you built a new swanky house, and you told, as a surprise, you told them, you put blindfolded them, okay, and you took them to the new house and told, now onwards, this is your new house. They will act confused and they may even start abusing you. Okay, so something as simple as change in environment can also be a triggering factor for a person who has high individual risk factors. I hope this is understandable. Are we all on the same page? Can you all come on the chat box and respond? Are we all on the same page? Is there any difficulty till now? Is there any part which you have been unable to follow? Are you all okay with the pace? Are you all okay with the slang? Any difficulty which you are facing till now? I want everyone to come on the chat box. There are 50 people, 52 people on this group. I want at least 50 responses. Or is it too much to ask? Okay, the usual people are responding. Sister Diana, Kulvinder, Gurpreet, Srilata, Kulasi, Sangeeta, Jagrup, are you all there? Suman, all right. So as we have already said, in certain situations, the delirium threshold is lowered. That is, if these conditions are there, the person can easily go into delirium. So extremes of age group, suppose it's a very young child or it's a very elderly person, the person is having some dementia or memory loss, the person is having hearing or visual impairment, the person is having alcohol abuse, the person has got a history of depression, the person has reduced physical activity. Okay, so if these situations are there, the delirium threshold is lower. That means easy, small triggers can lead to delirium. Now, triggering factors for delirium. One, as I told you, you want a change in, you wanted to gift a new house to your parent, you did a change in environment and they started abusing you. Change in environment. Unfamiliar excessive stimuli. They are lying down somewhere and there is a bomb blast outside. Unfamiliar excessive stimuli. Okay. General condition deterioration. That is, they are growing old, their intake is less, their physical activity is less, so their general condition deteriorates. Uncontrolled symptoms, like we had said, uncontrolled pain. Primary or secondary brain tumors. Primary means it is a brain tumor. Secondary means it is a lung tumor, but it has sent some deposits into the brain. So primary or secondary brain tumors, so directly it affects the brain function. Paraneoplastic syndromes. Paraneoplastic means cancer. So related to cancer, certain types of cancer, some hormones or enzymes may get released into the bloodstream, which goes and affects in the brain and leads to paraneoplastic syndromes. Biochemical disturbances, like we already told, glucose abnormalities, sodium, potassium, magnesium abnormalities within the system, and drug induced. Of course, if you are on some kind of drugs, these drugs need not be only illegal drugs, like I have been saying so far. It can be some legal drugs as well. Okay. If the person is in withdrawal states like alcohol withdrawal, if the patient has an organ impairment, for example, kidney or liver is not functioning due to liver failure or kidney failure they have reached. So there will be chemical imbalances in the system, which leads to delirium. If the person is sleep deprived, all of us, if we are awake for one night itself, the next day we'll be disoriented, right? So due to many of the kinds of illnesses, the person is sleep deprived. They are not able to sleep at night. So sleep deprivation can cause. Then some major surgeries, or if there is a trauma as well, these can be triggering factor. What are the types of delirium? Delirium can be hyperactive, like I said, aggressive, violent behavior, abusive behavior, or hypoactive as well. Hypoactive would mean that the person is not at all active and he is just sitting somewhere relaxed and not moving around much. Okay. And sometimes it will be mixed. Sometimes it will be hyper, sometimes he will be hypo. Usually it is a mixed type of delirium which is seen. Here you can see that there is, on the upper end, the person becomes agitated, and at the lower end, he'll be withdrawn as if he's in depression. So you can see a kind of waxing and waning pattern which keeps happening, right? So too much of delirium, if it goes above, it becomes hyperactive, it comes below, hypoactive. And this pink line in the center is called as the normal state. So in between, he will be having periods of normalcy also. So this will send the person into a lot of distress, because they'll start wondering that sometimes so he behaves very normally, sometimes he behaves abnormally. I'm not understanding what is happening. Please help me, doctor. Right. So how do you assess delirium? But before we go into that, let me just ask you a question. What kind of delirium do you want your patient to be in? I want Jagrup to answer this. Is Sister Jagrup here? Are you online? Can you either unmute yourself or can you come on your chat box and respond? What kind of delirium do you want your patient to be in? The others, meanwhile, you can respond on the chat box. Do you want your patient to have a hyperactive delirium? Do you want your patient to have a hypoactive delirium? Or you want a mixed kind of delirium? That is, in between you want your patient to be hyper, and in between you want them to be withdrawn and sitting somewhere quietly. Okay, Kanchan sister wants her patients to be in mixed delirium. Okay. Okay. Okay, Sister Evangeline. Few more responses. What kind of delirium do you want your patient to have? Okay, Priya sister wants hypoactive delirium. The people whom I'm calling the names of, if you don't respond by the end of the class, we'll be noting down your names and having a word with you. So Sister Jagrup, if you're there, do come online. Sister Bindu, would you like your patient to have hypoactive delirium or hypoactive? Okay, Sumit brother, like a true healthcare professional, we don't want our patient to have delirium at all. That's the best answer, yes. But many a times, suppose there are certain predisposing conditions because of which the patient is going to get a delirium. Most of us would prefer hypoactive delirium. Hypoactive would mean, okay, if he wants to get delirium, let him have hypoactive, so that he is simply sitting somewhere and not being abusive, not being aggressive, and not bothering somebody. Tracy sister, can you just unmute yourself and ask, why do you want your patient to have hyperactive? Is there any advantage of having hyperactive delirium? Sister Tracy Thomas. Okay, I'm just checking who all are there. Okay, so many a times what we would prefer the patient to be in is hypoactive delirium. Okay, but that's why many people have responded hyperactive. I just wanted to know, Maybe they are very interested in handling patients who are aggressive and abusive, or they see it so often that they have become good at handling them. Either way, usually we want the patient to be in hypoactive, if at all, because in hypoactive delirium, the person is not going to be a harm to themselves or to others around them. But remember one thing, that as far as this is concerned, in hypoactive delirium, the person can in future go for worsening much more. It will be much more worse, because you may not identify at all that the person is going in for a hypoactive delirium. You may just think that the patient is sitting quietly thinking about his disease condition, and so he's being quiet, maybe a little depressed about things. But if you don't treat delirium, whether it is hyper or hypoactive delirium, in future it will worsen the general condition of the patient, as well as it will cause a lot of distress to the patient. So as you can see, there are many assessment tools, and the most commonest one which we'll be looking into is confusion assessment method, or CAM. So what is confusion assessment method? The confusion assessment method has got 4 features. Out of these 4, 2 have to be there and either of the next 2. So one is, it has to be an acute onset. Like I said, acute onset need not mean that it has to be within a few minutes. It may be a few hours or even a couple of days. Or it has to have a fluctuating course. Like I said, sometimes it is normal, sometimes abnormal, fluctuating course. The patient is having inattention. We look at how we can assess inattention. Along with these 2, they should also have either disorganized thinking or altered level of consciousness. If all these are there, that is 1 plus 2 and 3 or 4. If any of these are there, then we will call it as the patient is having delirium. So acute onset and fluctuating course, we said, is being confused. They may be admitted, but they will say that, no, I am not in the hospital, I am at home. Or they may be at home and they will say that they are in the hospital. And they may say that they are seeing things which are not there. They'll say that there is somebody standing behind the curtain with a knife waiting to kill me. These kind of things may be there. So acute onset and fluctuating course, inattention. How do you check for inattention? So you can say a digit span. For example, 1, 2, 3, 4. You will tell the patient to repeat 1, 2, 3, 4, but backwards. So they have to say 4, 3, 2, 1. Okay, so you can make it difficult for them. You say 5, 6, 7, 8 or something like that. Okay, so they have to correctly say it backwards. Or you tell them that say from Sunday to Monday, but backwards. Okay, or you start from December and tell till January. So everything backwards. If they are unable to say that, we'll say that they are not having attention or they are having inattention. Disorganized thinking, you can simply ask which is the current year or which day it is today or where are you right now. An altered level of consciousness. Some of them may be very alert, very vigilant. Some of them may be lethargic. Some of them may be stuporous or comatose, like some of you. Maybe I am right now, I'm not sure because I'm unable to see you or your responses. So altered level of consciousness, right? So that is how we look at CAM, that is CAM. Now there is another method as well, which is called as the 480 method, which is a very simple way of looking at it. Okay. Here also it is having a similar way of looking at it, like alertness is looked at, the age and things like that of a person is looked at, the current, what if he is able to correctly answer the age, current year or his date of birth, if he is able to give correct answers, if his attention is proper or not, or if there is acute fluctuating course. Now the advantage of this is if the score is 4 or above, the person is having delirium. So you need not ask all the questions. You can see the first question under alertness, the mark is given as 4 if the alertness is clearly abnormal. So you look at the person and he's behaving abnormally or having abnormal alertness, directly he gets a score of 4. Then you don't need to look at inattention and disorganized thinking or something like that. Directly you give a score of 4 and you conclude that the person is having delirium. Easy bedside test. Okay, so that you don't have to spend much time as well. So how do you manage delirium? Remember always that because there are so many causes of delirium, always you correct the correctable cause. Whatever is the cause of delirium, you have to correct it. It may be as simple as getting a spectacle or getting a hearing aid for a patient. Okay, it may be as simple as that. So always keep in mind, correct the correctable. Next is you always look at non-pharmacological methods of treatment. That is, you don't directly look at drugs to give drugs. And only after the non-pharmacological is tried, then you will go for pharmacological management. That is, you look at the using drugs. Now remember one thing, there are certain conditions which can mimic or act like delirium. I'm sure at least some of you must have thought of, how will I know whether the patient is actually having a hypoactive delirium or he's in depression? How will I actually know that if the patient is having delirium or he's having some form of psychotic break? Okay, so you can look over here. Do you expect depression to start suddenly? Can you come on the chat box? Do you expect depression to happen suddenly? Okay, Sister Sunita thinks no. Right, so always there'll be some background to a person going in for depression, right? So is that the situation with delirium? No, in delirium, the person may be all right till yesterday or till today morning, and by evening he is worsened. So you can see in depression, acute changes are not there. Okay, altered consciousness is not there. They will be alert. They won't have any disorganized thinking. Now, some people may have dementia, that is some loss of memory. Again, it won't be acute. It will be slowly happening over a period of time. Now, again, a person who is having psychosis, may not have altered consciousness. He'll always be alert. Okay, he'll be alert. There is no waxing and waning pattern usually seen. So these are certain of the parameters through which you can differentiate between delirium, dementia, depression, or psychosis. Right. So what are the non-pharmacological measures? You may be thinking why a nurse should know this in so much detail. Because you people are the ones who are there with the patient for majority amount of time. You are the ones who are closely interacting with the caregiver and the patient for longer periods of time, doing so much for the patient, whether it be giving food or giving medications or ensuring that some injections are given or asking for the general well-being. So for everything, the sisters or the brothers are the ones who are always there as a first line of contact. So non-pharmacological measures, there are many of them, and it is of mighty importance before you go for drug-related therapy. So let's start looking at it one by one. So there are some of them which will be nearly 7 of them. There are more methods as well. Let's look at some of them. How can you optimize sleep-wake pattern? A person due to his illness has stopped sleeping at night and is awake during daytime. How do you expect the person to be normal? Obviously, he will start becoming disorganized in his thoughts, right? So you have to increase the exposure to sunlight. Suppose a patient comes to the ward, new admission, you know there is a history of delirium in your primary assessment. You have to give a bed which is closer to the window, because when the window is hitting, when he's lying down near the window, there is sunlight during daytime and there is darkness at night. And mind you, only when darkness happens, there is something called as melatonin, which is secreted inside the brain, because of which we start feeling sleepy. This is one of the reasons why we want to have lights off so that we can sleep comfortably. You should have a low level of light and noise. Do you expect a patient to sleep well in the ICU? I don't think so. Then have some sleep protocols. Okay, some people, they want to have a slight head massage before they go to sleep, or they want to have some warm milk with some turmeric in it before they go to sleep, or they want to listen to some calm music before they go to sleep. So identify some sleep protocols for the patient, because of which the patient can go to sleep properly and you can optimize the sleep pattern of the patient. Next is patient orientation. Many a times you have to, the patient may not be oriented. Like we said, he may keep thinking that he is at home, or he may think that he is in hospital or whatever. So you have to keep explaining to the patient that where he is, what happened to him, who are the people who are with him, who are you to him. These things you have to keep explaining to the patient. Can any one of you tell me a movie where a person had to take so much help of keeping on orienting himself regarding what he is doing, where he is? Can you come on the chat box and respond? At least for this, people who have not been responding, if you can respond. Yeah, Sister Evangeline has hit it. Bullseye. So basically it is our Amir Khan who had written stuff all over his body so that he can remember and be oriented to what he was supposed to do. So when you don't have to scribble things on the patient's body, okay? Otherwise you may be sued, or the patient, non-delirious patient may also have abusive or aggressive behavior. So what you can do is have a whiteboard in front of the patient where you can write down things for the patient, and maybe which year this is, which hospital this is, what location he is in, and always have a clock so that the patient can look at the time always. Communication. So communication is good in the sense we need to ensure that the patient is able to communicate with us properly, and whatever we are communicating is being received well by the patient. So eyeglasses and hearing aids, okay? Dentures, that is so that the person can communicate properly. Otherwise, you know how old people talk, right? I'm not going to mimic it right now, but without dentures, also communication suffers. Encourage mobility, mobilize the person as much as possible, okay? If the patient is lying down most of the time, ensure that at least for the meals, he's sitting up. Avoid using restraints, physical restraints. Many a times out of irritation, we tend to tie the hands and legs of the patient to the railing of the bed. Would you like your hands and legs to be tied due to whatever reason? If suppose for whatever reason I tie your hands and legs, what will be your reaction? Come to the chat box. Come to the chat box. If I start using physical restraints on you, what will be your reaction? Are you going to be happy about it? Right. So you're going to be angry, you're going to be anxious, you feel harassed, right? So just imagine that a patient who is already not feeling well, who is already in distress, who knows that something is not right with him, and you're tying his hands and legs to the railing. On top of that, there'll be all these monitors beeping and people are laughing and giggling around. He's going to definitely gonna have a hard time, right? So avoid using physical restraints as much as possible. And minimize use of catheters, because catheters themselves, one, it will reduce mobility, two, catheter can cause infections as well. Next, as I told, monitor bowel and bladder habits. Every single day you should ask your patient, have you passed stools? Was it difficult or not? Do you feel still uncomfortable? Is there any urinary retention? Do you need to catheterize this patient? These are things which you should consider on a day-to-day basis and treat them accordingly. Is Sister Vinita listening in deep concentration with eyes closed, or in meditation in the afternoon time? Early mornings and evenings are good times for meditation, not immediately in the afternoon. Okay, provide support and education. Many a times, looking only at the family, looking only at the patient, we forget about the family. Many a times we need to educate and support the family members as well. Extremely important, because even when the doctor moves away, even when the nurse moves away, it is the family member who is there 24/7 with the patient, right? So, so counseling the family, educating them about the situation, that you think the cause of delirium is this, so we need to look into some investigation. It may take some time. We may have to start some medication, or we are going to try without medications first. So during the meanwhile, it will be slightly difficult for you. I can understand that. But just do not get angry on the patient. Reassure the patient in a calm voice, reorient them, and just be calm, so that you don't cause any further distress. And like it is with all situations in life, there is absolutely no point in getting angry and agitated yourself. So have a calm mind, understand the facts which is happening with the patient right now, and deal with the situation. Now coming to pharmacological management. After you have tried all these things, nothing is working. Now you want to give, doctor, I'm not able to manage this patient, just do something or discharge the patient. So doctor, no, I'll give some medicine and see. So we come to pharmacological management. So there are 4 situations in which you have to consider giving medications. One, non-pharmacological methods have failed, or the patient is severely distressed. You can see he is angry, agitated, aggressive, or whichever way. He is distressed basically. Or the patient is a risk to themselves or to others. They may cut themselves or they may cut you, or the person who is lying down on the next bed. And 4, they are having agitation. So basically, 2 things. One, distress due to perceptual disturbance. They are feeling that somebody is lying down beneath the bed and he's having a gun in his hand. The moment, sister, you go, he is going to shoot me. Or second, if there is agitation, angry, agitation, abusive language, because of which it is causing issues. So basically 2 target symptoms: perceptual disturbances like hallucinations and agitation. So the class of drugs which we use for this kind of behavior is called as antipsychotics. Mind you, just because the word is antipsychotic doesn't mean that we will give the medication only when the patient is in aggression. You should equally identify when the patient is in hypoactive delirium. That is, he's having some abnormal behavior, abnormally depressed, abnormally quiet. Suddenly, he's having these kind of things. Then also you may want to start them on antipsychotics. And the drug of choice usually is a drug named as haloperidol, which can be given orally. It can be given IV. Now, if nothing is possible, you can also give subcutaneously, that is below the subcutaneous tissue. Now, benzodiazepines. You would have heard the term benzodiazepines. You would have heard the terms midazolam and lorazepam. Whenever you want the patient to go to sleep or become less active or become less aggressive, you use these drugs. But mind you, again, benzodiazepines should be used only when there is hyperactive delirium or when there is aggressive behavior. Okay. Otherwise, as far as possible, for hyperactive delirium or whenever you can manage with just haloperidol or other medications, you will not use benzodiazepines, because benzodiazepine can worsen delirium as well. So always have this in mind, that benzodiazepines can worsen delirium, and you will use it only and only when there is hyperactive delirium. That is, the person is having aggressive behavior. So there are certain antipsychotics which we very commonly use. And the ones which I have highlighted over here, or I put in the red box, are the ones most commonly used. That is haloperidol, quetiapine, risperidol, and sometimes olanzapine as well. Now you can see that there are certain side effects as well for these drugs. Some may cause lot of sedation, that is, they feel after giving it, the patient's family members will tell that the patient is sleepy all the time. And some may have some worsening of Parkinson's, because as we already told, there is excess of dopamine, right? So there are certain medications because of which it can increase the delirium because of the effects on dopamine. So there are certain side effects. Just know that there are certain side effects as well which can happen with use of drugs. So what is our conclusion? The conclusion is always correct the correctable. Whatever cause you can correct it. Go for non-pharmacological management as far as possible. Many a times a multidisciplinary approach may be needed. Sometimes you may have to take the help of a psychiatrist to ensure that this is delirium, but the patient doesn't have some underlying psychological illness. Communicate and take the caregivers along. Always take the family members along. Make them understand. It may be a little time consuming, but it will give you a lot of satisfaction to see the way the family members will handle the patient and the situation also. So they understand that this is going to take some time. So every time something abnormal happens, they will not end up calling, sister, he's behaving like this, sister, he's saying like this. To avoid that kind of calling also, you need to communicate with the family members always. And lastly, always identify hypoactive delirium. Like many of you told, you may want the patient to be in hypoactive delirium preferably, but a person in hypoactive delirium may not get treated for long periods of time, which will lead to worsening of their illness and will give severe distress. And more importantly, towards end of life, it will give a bad, distressing death to the patient. So always identify hypoactive delirium and treat it. I think I've reached the end of my presentation. Please feel free to come and come on the chat box or raise your hand and ask doubts or give your comment. Or if you feel fine and we can proceed, then please type so on the chat box. We'll be proceeding only after a majority of you respond. Has it been clear for you guys? Are you feeling at least somewhat you have understood what delirium is and what should be your approach, how you can identify delirium? Is there any doubts? I want more people to respond. Meanwhile, Sister Evangeline, you can get ready for your presentation. Sister Ji, are you sitting in a garden? I can see a lot of grass around you, grass and trees.
No, sir, it's just a background.
Okay. Sister Ji, where are you working? Where are you from?
I'm from Atulya Assisted Living, Chennai, sir.
In Chennai.
Yes.
So, since majority of you are making it clear that there is nothing to ask or nothing to tell, then we are going to hand over it for some time to Sister Evangeline so that you can have the case presentation. Questions will be going to the audience itself, so ensure that you listen because my throat is slightly irritated after talking for so long. Okay, sister, you can start off.
Good evening, sir, and good evening, everyone. I am Mrs. Evangeline Solomon from Atulya Assisted Living. I would like to do a case presentation on delirium. So my client name is X with an age of 90 years, male. So he is diagnosed with BPH, metastatic lung cancer, CAD, DM, hypertension, and hypothyroidism. So he has been transferred from other institution to our institution with a metastatic lung cancer. The primary source is unknown. So he just came to us for palliative care. So the present complaints when he came here, we received with 24 hours O2 support, like about 2 to 4 liters in O2 concentrator, and general deterioration, cough on and off, decreased urine output with thick pus, and acute confusion. Only at the night time. Morning time he will be a bit cheerful, and only in the night time he might be shouting, and disoriented with time, place, and person. And in frequent time he will just remember, then again he will forget. Then wakefulness, insomnia, and nocturnal agitation. In the night time he used to sing a lot aloud and called help for the staffs. So these are the present complaints he came with us. So the history of illness is resident is known case of metastatic lung cancer. As I said priorly, primary source is unknown, and they don't want to discuss about it further. Like they don't want to go for a rigorous treatment. And diabetes for past 10 years and hypertension for 5 years.
Sister Ji, can I just interrupt you for a minute?
Yes, sir.
Yeah. Can we just go to the previous slide?
Yes, sir.
One more previous slide, presenting complaints. Right.
Yes, sir.
Can you all come on the chat box and tell what are the issues over here? Or probably I think there are many over here, so I'll just ask somebody. Gurpreet Rai, are you online? Are you available? Can you just come ahead and tell that looking at this presenting complaints, what all do you think are the issues which can cause delirium over here? Okay, Sister Srilata. Is Sister Srilata here? Can you unmute yourself? Meanwhile, others can respond on the chat box. Yes, Sister Srilata. Can you look at this slide and tell me that what are the factors which you can look at and tell that this is a risk factor for causing delirium? Yes, Sister Ji, we can't hear you. Can you be a little loud? Okay, Sister Ji, why don't you come on the chat box and give your inputs? So like many of you are saying, yes, decreased oxygen supply, like we said, any insult, right? Insomnia, general progression, yes, Oyo. Can you just come up on the chat? Yeah. Decreased oxygen supply, yes, come down. Yes, okay, there is acute confusion. There is disease progression, disorientation, insomnia is there. Can you see there is thick pus in the urine, which is showing that there is a possibility of infection as well. Yes, pus in the urine, decreased urinary output. Very correct, Sister Priya. Bowel and bladder problems, yes, yes. Okay, let's move on. Sister Evangeline, please continue.
Yes, sir. Then history of illness, as I discussed.
Yeah, already mentioned. Next slide, please. Yeah. What did you find on examination? Yeah.
Examination, the temperature is on and off 100 to 101, and GCS is 13/15. Sometimes mood swings. At the night time, he sings aloud and shouts and call for help. Then the urine output, we noted thick purulent urine draining from his penile region. Although from the urinary catheter, but still we noted from the penile region with an offense order and decreased urine output. So these are the examination findings we have found. Next slide, please. So WCC 14.1 and potassium 4.4, urea 3.8 and creatinine 78. So the major issues with them, they are not ready to do any investigations, and they are not going for any aggressive treatment, even though they are not agreed to go for the IV antibiotics, because the client and the family are aware of their illness and they really want a peaceful death. Since it is a palliative care, they don't want to do any aggressive treatment, so they refuse to go for IV antibiotics and do go for other treatment or shifting to hospital.
How old was the patient? Sorry, I forget. How old was the patient?
90 years, sir.
Okay.
And next. So psychological aspects, before actually he has some fever. He was living alone in a home before getting sick. He was in the Coimbatore and suddenly he got fever and there was no caregiver. And he was admitted in one of nearby hospital in Chennai. And from there he came to us. Before that, he was very independent, enjoy in reading newspapers, enjoy in cooking. He cook himself, likes foods very much. He likes to try different foods. And even when he is sick, the day actually he has passed away. Even the day before he has passed away, he preferred to eat pav bhaji and whatever he likes to eat, he ate. He has ordered on ate on that day. So this is the psychological aspects of the side. Then next. Medication, he was on tab fan 40 mg OD, tab amlong 2.5 mg BD, and tab thyronome 100 mcg OD. So they don't want to go for any active cancer treatment or don't want any medications to be followed. So next slide. So main concern, family and the resident wants peaceful death and don't want vigorous treatment for metastatic cancer and asked to manage with the minimal medications. And resident was developing urosepsis on management with only oral antibiotics. So we insisted that we cannot leave him like that. So at last they accepted, he himself have accepted for the oral antibiotics and he refused for IV antibiotics. And next page, next slide. So the summary would be a 90 years old gentleman was having a present complaint with weak and 24 hours O2 support, general deterioration, cough, decreased urine output with thick pus, acute confusion, disorientation with time, place, wakefulness, insomnia, and nostril agitation. So at last we started only with oral antibiotic tab septum 500 mg BD, and resident is on palliative care, and family and resident refused for IV antibiotics and any other vigorous treatment. Next page. So points to be discussed: family, patient and family counseling, nutritional management, and O2 support for 24 hours.
Okay. Thank you, Sister Ji. Can you come to previous slide? Yeah. Sister Suman, can you unmute yourself? So, Sister Ji, you have seen that there were certain conditions which this person had. Sister Evangeline, he has passed away, right? He passed away a couple of days ago. May his soul rest in peace. But just for the sake of discussion now, consider Sister Suman, this was the patient which you are seeing. What are the things which you think are correctable or was correctable for this person? Sister Suman? Sister Carol? Yeah. Suman sister is here? Yeah, tell me. Okay, mute her off. Sister Carol, can you come online? Can you come unmute yourself? What are the things which you thought could be corrected in this person?
Actually, I was not able to see the whole presentation of the person because I'm having some network problem. But as I can see can we have the previous slide? In that it is shown he was not oriented to time, place and person. And as discussed in the class earlier, for the time, we could have kept him with a clock, could have done certain things like that. Like in a room, we could have kept clock, made his bed near the window and decrease. And for the nocturnal agitation, that was because he was having insomnia. So treating his insomnia by giving him some sleeping pills and all would have helped.
Okay. Thank you. Sister Chanpreet, do you want to ask any question to Evangeline? Something you want to clarify? What you could have done better for this patient? Sister Kanchan is saying that the RFT report is not written correctly. Can we just go to that slide? Yeah, creatinine is 78. Okay, I think there is some mistake over there. Maybe it is 7.8 or something like that. Possible. So there is a organ impairment as well. So Sister Evangeline, just out of curiosity, did this patient have to go into the ICU?
Sir, he was previously in the ICU and discharged from ICU and came back to us. After that, they don't want to go for any vigorous treatment. So when we received for 2 days, he was quite okay. But after 2 days, we received on 11/7. Then we on 14th we noted temperature of, then pus draining milk and the urinary catheter. So that time we really want them to transfer to hospital and check what really goes wrong. Maybe he may go for sepsis, whole body sepsis. So we tried our maximum. We spoken to him and to her daughter. Daughter was the only person with him. So, but that time the client himself said that he don't want to go for any treatment because if you go there, they will give some vigorous IV infusions and it will cause pain. He is aware that he have some issues and going to pass away. So he wants a peaceful death. Like he wants to eat whatever he wants to eat. He enjoys a minimum time with her daughter. So they really refuse to go to hospital.
Okay. Just out of curiosity again, was this person having continuous delirium or was he being normal in between?
No, sir, it's like mixed because morning time he used to chat with us very nicely. He orders his food of his own. He will tell what he wants to eat and other things. But at the night time only we face this issues. Like in the night time, he will sing very loudly. That is incoherent. Then he will talk to somebody. Then he's saying his wife is standing. Only night time we used to experience this type of thing. But morning he will be okay, sir.
Okay, brother Namono, can you please unmute yourself? Now you have this person who is here and who has been saying that, as the sister is saying, at night time he's having more issues. How would you like to manage this person? Brother Namono?
I think we.
Oh, sorry, sister. Sorry. I'm so sorry. Just the video of it was not clear. I'm so sorry.
It's okay. We give him some sedative drugs that can cause them to sleep. To have
You want to
sleep.
directly give a sedative drug? Or do you want to do something else? Is there something? Okay, the doctor has not arrived yet. Okay. So the doctor has not arrived yet, but the patient is looking at you and the family is looking at you.
I think we can give amitriptyline, if that's the pronunciation.
Okay, but then, okay, so I'm saying that you don't have access to the drugs right now because the doctor also has not come yet. Okay. So can you do something simple things? The patient has just come to you and you want to do certain things for the patient. Can others respond on the group, on the chat as well? It will be great. Sister, you can continue meanwhile.
Okay.
You can continue, Namono. You can say what else you would want to do other than giving drugs. So, Sister Namono, according to you, do we go for pharmacological therapy first or non-pharmacological therapy first?
We can keep around with the patient to talk to them to ensure that they are not destructive.
Right. So like many of you are responding now, you want to provide first a comfortable environment. And because this person, as sister told, that towards night there is an issue. This phenomenon is called as, anyone for virtual chocolates? Can you name this phenomenon, what it is called as?
Sundown syndrome, sir.
Yes, it is called as sundowning phenomenon. Okay, that towards sunset or sunset phenomena, like once sunset happens and it starts becoming dark, the person starts having abnormal behavior. Okay, So this is called as a sundowning phenomena. Again, you have to ensure that as a simple thing, before you think about medication, place the patient in besides a window. And one very common thing which you can do. Apart from that, for the family, Sister Rafina, would you want to say, what would you say to a family member of such a patient? He has come with all these symptoms now. What do you want to tell to the family member, Sister Rafina? Sister Rafina went off the video the moment we asked her something. Sister Sunita Mato, you can unmute yourself and talk.
Sir, relatives already decided for peaceful death. So somehow we will counseling and we will give some spiritual support to the relatives.
Right, very, very good, very important aspect you have brought out, Sister Ji. Sister Evangeline, was anything like that done? Did we offer something or did we inquire anything like that?
We have asked for like some puja to be done for him. Then the family themselves, based upon their religion, they bought a priest and they do some prayer for himself before like he's passing away, sir. So we addressed that side too.
Okay. So there are a lot of aggravating factors in this patient. One thing is having cancer and he's having some form of infection as well. I think that he's on oxygen support for 24 hours. There is some amount of breathlessness which will be happening because there must be spread to his lungs as well. So I think that one of the sessions you would have dealt with, I'm not sure. Is there a role for any opioid in a person who is having breathlessness? I want others also to respond on the chat box. This is probably the last few final responses which I may ask from you. Those who don't respond will be marked absent. Is there any role for any opioid in breathlessness? This person is we are saying that is having continuously requiring oxygen, which may be distressing to always have something on your face, you know, a mask or a nasal prong with some air going in, some pressure all the time. It may be very irritating. Sister Ji, do you want to answer? Sister Evangeline?
We're asking for, do we need to give any opioid?
Yes. Is there a role for any opioid in a patient who is having cancer with lung metastasis because of which he is unable to breathe properly?
Yes, we can provide, sir, because in metastatic cancer, he may go for severe pain, right? So we can suggest opioids for him.
So always remember that due to any cancer, one is even without pain, if there is lung metastasis, that is in the lungs there is metastasis, and if the person is having difficulty breathing, you can give a very small dose of something called as morphine, which is an opioid, right? Yes, Sister Aditi, you can give bronchodilator nebulization and stuff like that, but you look at the pathology also. Okay, there should be a bronchus in the first place, right, for it to dilate. Only if a bronchus is there, then you can dilate it. But that has got obliterated with a ball of mass over here right now. So there is nothing over there where even if you give this nebulization, it may not end up reaching over there, right? So there is something called as a drug called morphine, which you will be hearing if you have not heard yet, which we start on a small dose. It will help the patient to decrease his breathlessness and work of breathing, and he'll be much more comfortable. Okay, so just an additional point for you. I think we are just 1 minute away from 4:30, and Sister Evangeline, you've done a fantastic presentation, presented really well.
Thank you, sir.
Okay, keep it up. Sister Kanchan is saying we can use WHO ladder. Yes, for pain, you can use WHO ladder, of pain, but sometimes if the patient is in very severe pain, you can jump the ladder also. You can directly go for a strong opioid as well. Okay. Any doubts you have, anybody? Feel free to post your comments, your questions on the chat box, or you can unmute yourself and ask as well. And for all those who have not responded yet, you can put reasons as to why you have not responded so that we can look into it. Another 30 seconds and then we'll be off. Takeaway message. One takeaway message from the session which you have heard in the last 1.5 hours. I'm just asking you one takeaway message. Post it on the group. Post it on the chat box. Instead of saying thank you, that is okay. You can thank later, not a problem. But more importantly, I want one takeaway message or one takeaway point from what you have learned in today's session, which you think you can take away in your practice, day-to-day practice. It can be anything, whatever it may be. You learned symptom management, or you learned that non-pharmacological management has to be first, or it can be anything, whatever, one takeaway point. Just start posting, please. At least that much satisfaction you should give me after all the non-response. Okay, Sister Sunita, it was very useful to identify types of delirium. Yes, always identify hypoactive delirium as well. Yes, Sister Evangeline, opioid use of morphine, it is not only used for pain, but also for breathlessness. Sister Kantan, yes, pharmacological management where we use something called as antipsychotics. I think many people will have to be marked absent today. I don't know if you'll get your certificates if this is how the response is. Two more minutes. Sister Kulvinder, non-pharmacological management is very important. Yes. Sister Carol, types of delirium and management of different types and approaches. Yes, causes according to delirium. So delirium itself stands for, it's an abbreviation. So yes, causes of delirium. Don't forget the S at the end of delirium. Deliriums, it is. So S stands for subdural hematomas. Yes, Sister Namono, we should minimize restraining patients. It is extremely irritating and it can do more damage to the patient than helping them. Yes, there are triggering factors. Sister Nancy Joseph, extremely important. Always remember, for a person who is having low individual risk factors, they need high triggering factors. And for a person who is having high risk individual risk factors, even something as simple as change of environment can trigger a delirium. Management by non-pharmacological means is almost always in the hands of the nursing staff. The doctors may just come for 5 minutes and advise some medication and go. But nurses have got a huge role to play in symptom management as well. So on that note, I think we'll stop taking comments. Thank you so much, all of you.